previous speaker, because a lot of what Dr. Harjeet said about the causation of the thrombosis, practically a lot of those same inflammatory cytokine mediated pathways are applicable when we talk about the other side vascular complications, that is the arterial lesions. So briefly, I'll be talking a bit about acute pancreatitis, chronic pancreatitis, sometimes surgery for this leading to arterial lesions happening. Vascular complications are seen both in acute and chronic pancreatitis, and up to 25% of patients will develop vascular complications. Arterial lesions, most commonly that we encounter is a pseudoaneurysm, and occasionally we would see thrombosis as well. And arterial lesions, most commonly they would lead to a life-threatening hemorrhage and occasionally infarction from the thrombosis. More commonly the infarction would be secondary to endovascular intervention. Most important difference between arterial issues in pancreatitis versus the venous issues would be, like Dr. Harjeet said, venous issues would, by and large, the management would remain the same and the medical management would continue, but the arterial lesions will definitely need something because the risk of life-threatening hemorrhage. Usually, the spontaneous ones would be related to the same inflammatory pathways. There will be endothelial damage, there will be enzymatic degradation of the walls of the vessels leading to arterial pseudoaneurysms, and then the pseudoaneurysm, part of the pseudocyst, it could rupture into the lumen, or it could just rupture into the, it could be an extraluminal hemorrhage into the abdomen leading to hemodynamic instability. Sometimes the patient may just present with abdominal pain and bleeding. Post-operative are the ones wherein some of them could actually be the ones which are not missed on the imaging previously, and sometimes you could find some of them which could be related to some surgery, because at the end of the day, you're trying to do a safe debridement, but quite often the lot of necrosis is there close to the vessels. Important thing is to stay away from them and just try to take out the loosely placed necrosis as much as possible. Pseudoaneurysms seen both in acute and chronic pancreatitis, usually seen 3 to 4 weeks from the onset of acute pancreatitis. The incidence varies across reports. There is probably a higher incidence in males. The size could really vary. I still remember there was a 6 centimeters pseudoaneurysm which Professor TKC, who was just sitting here in the audience, operated while I was a resident there. I have never seen one such pseudoaneurysm since. But then most of them would be small, and even small ones could cause a lot of hemorrhage. Most commonly it affects the splenic artery. However, the other vessels in the vicinity, which could be the gastroduodenal artery, the left gastric artery, the superior inferior pancreaticoduodenal artery, the dorsal pancreatic artery, sometimes the superior mesenteric artery and its right colic, middle colic, or the jejunal branches could also be affected. Quite often, these pseudoaneurysms would be picked up as an incidental finding when you are doing a scan for a patient who's clinically not doing well in acute pancreatitis, or sometimes when some treatment is being planned for this patient for chronic pancreatitis, at that time you've picked up a pseudoaneurysm. Occasionally, what is reported quite often in literature is just like a Harald bleed is reported on a Whipple, is something which has also been reported for pancreatitis pseudoaneurysms, and the bleed could again be intraluminal or extraluminal. Extraluminal would generally be apparent in a patient only if the patient had a percutaneous drain. Otherwise, it wouldn't really show up. And sometimes, occasionally, you'll have a patient who's gone home after pancreatitis, was recovering well, and the last scan didn't show up much except some necrosis, and then suddenly this patient presents with a massive bleed with quite often pain, and sometimes there could be hemodynamic instability. The bleed could be intraluminal, and if it's an intraluminal bleed, it is called hemosuccus, and it would present as a GI bleed. Either the patient would have hematomesis or sometimes hematochysia or melena. And extraluminal hemorrhage would generally present with sudden onset abdominal pain, distension, the patient suddenly having a lot of sweating related to the massive blood loss. When we come down to diagnosis, CT scan remains the mainstay of diagnosis, which has a very high sensitivity for these lesions. Angiography is usually considered gold standard for the smaller lesions, but at the end of the day, quite often these patients are sick and you don't want to really give too much of a contrast. So most of the interventional radiologists, they need some kind of a roadmap. So you would end up doing a CT angiography. It's only that you have a patient who continues to bleed, and then the CT angio is showing a bleed but not able to show up anything, that you would want your IR guy to just go in blindly and try to cannulate these vessels and try. And most often it will be reserved for identifying the bleeding site and guiding the endovascular treatment. This was a very useful pseudoaneurysms classification, essentially trying to say that what we are talking about is whether it's a small vessel or a big vessel, and how likely it is that whether you can just embolize it completely or how much you need to preserve the vessel, because practically it would be, if you look at type 3, it is a major artery which cannot be sacrificed. So that artery, you will have to put a stent or something. You cannot just embolize the artery. And if you have a major artery which can be sacrificed, even though there is a communication with the GI tract or exposure to the pancreas, you're not really worried. Minor artery, you can very safely do an endovascular treatment, and therefore this classification becomes very important, planning endovascular treatment. You would obviously need to initially manage these patients with broad spectrum antibiotics, resuscitating, arranging adequate blood. These patients can really bleed a lot in a very short span of time. So centers managing this should have blood facilities, and appropriate ICU management has to be available. Endovascular management would succeed in controlling the bleed in majority of the patients. Now that's a fact. And that's what I was discussing with some of the people I was sitting down there was, the best is if your IR guy is able to control the bleed and with the rider doesn't cause a major infarction. So now the biggest challenge is that you will be able to arrest the bleed, but sometimes if it's a big vessel which has been embolized, or if the patient has had repeated episodes of bleed, and for that area you embolized all the collateral vessels, then you may end up in a situation where you could have gastric necrosis, transverse colonic necrosis. So all these things are important. When you place the stent infection, displacement and migration remain issues. Because we know that pancreatitis remains kind of an ongoing process. The infected necrosis is probably still there. Endovascular management, you could just, if this is a small outpouching, you could just pack it with coil. You could do, if it's a small vessel, you just block both sides. You could even do a percutaneous, as has been shown in this picture. And sometimes if it's a major vessel with a side pseudoaneurysm, you could just coil that pseudoaneurysm and place a stent as well. Some patients with, most importantly, with concomitant complications. Obviously, if there is a failure of endovascular intervention, you would be forced to operate, but we have to understand that quite a lot of these patients are going to have a significant morbidity and a very high risk of mortality. So the important thing is, if you've got a patient who's got a lot of residual necrosis, then probably the only thing that would be different between arterial and venous lesion is that venous lesion, you wouldn't really change the indication for necrosectomy. But if you have an arterial lesion, and it was a difficult to tackle arterial lesion, then you would probably expedite the management of the necrosis in this patient, whatever be the means, be it percutaneous, be it endoscopic, be it surgical. But you would rather be happier taking out all the infected necrosis in this patient. If you have a gross hemodynamic compromise, you could consider surgery. But again, as interventional radiologists have become more and more familiar with the procedures, what we have found is that it is better probably in these patients also to try endovascular intervention, because they will be able to reach the artery much faster than us. You try to take this patient to the theater, get to the vessel in amongst all that inflammation, it's really difficult to figure out what exactly is happening. The vessels are never seen on the table like they are seen on the CT scan, that's for sure. Surgical procedures could be a direct vessel ligation. Sometimes you would need a hollow viscous resection or some kind of a diversion. If you've got a, say, a right colic, middle colic artery pseudoaneurysm which your IR person has embolized, very significant chance that you may have to do a divergent stoma or something in these patients. Thrombosis per se is reported less often, more often seen in smaller vessels than in major vessels. And again, the same way, the role of anticoagulation is not really, antiplatelets is not that clear. Obviously, you got a major SMA thrombosis, the management of that would become very, very imperative. You may end up doing whatever it takes to manage that, streptokinase, endovascular management, whatever. And then, but you will have to just manage it because the SMA has to work. Coming to treatment, as already discussed, management depends on the vessel involved and the extent of thrombosis. Most often you would try endovascular management, try with the IV heparin. Low molecular weight heparin generally works fine. You can stop that for 12 hours and go ahead and operate the patient if need be. However, how long to give that anticoagulation remains very unclear. And most important thing is, if you've got infected necrosis there, then probably it makes good sense in trying to tackle that. Coming down to chronic pancreatitis and the arterial lesions in chronic pancreatitis, the vessels affected become a bit different. Splenic artery becomes much more commonly affected, followed by GDA and the superior inferior pancreaticobiliary. It is very uncommon to see a pseudoaneurysm from the mesocolic vessels or the jejunal branches or the left gastric artery for that matter in a patient with chronic pancreatitis. And these patients would be patients who would have had chronic pancreatitis pain for a period of time. There is sudden worsening, and then the patient has unexplained anemia, GI bleed, sometimes an abdominal distension, or occasionally with an hemodynamic instability. Most patients actually present when they've just had some bleed, they'll have worsening of pain without much hemodynamic instability. The diagnosis remains on the CT scan, and then initial resuscitation, the same IR procedures, and then surgery. Here, the indication for surgery would be, even if the arterial lesion has been managed by endovascular management, it would be imperative to start constituting some kind of definitive endoscopic or surgical management for this patient for the pseudocyst, because in chronic pancreatitis, the pseudoaneurysms would generally be related to the pseudocyst. At this point in time, it would be good logic sense. There is very little evidence to support it, but it makes a lot of sense in trying to tackle the pseudocyst around that time when you're tackling the pseudoaneurysm. Maybe a day or two you could wait just to see how things are, the bleed has stopped and everything else. Post-operative, you would see equally commonly following both surgery for acute pancreatitis. I honestly don't know how many of them we have created and how many of them were related to the disease pathology. But then surgery for chronic pancreatitis, yes, there is enough support in the literature. So this is one of our patients who had a big pseudoaneurysm. This was a big pancreatic head necrosis projecting into the right colon. At the primary surgery, when we had done a necrosectomy after a failed endoscopic management, we had done a diverting ileostomy on this patient, and day 2 this patient was comfortably sitting in the ward, suddenly bled massively, and then our IR colleagues just did embolization. This video doesn't play. So this is post embolization picture. I'll try this again. Yeah. So you can see this area filling up. This is the area where there was a big bleed or pseudoaneurysm which was tackled nicely. This patient never needed surgery and recovered again. Nicely done phrase at surgery. Day 2, suddenly the patient shows up blood in the rise tube with rising pulse rate. And important thing to understand, especially for the young colleagues, is that when you have a post-phrase bleed and you've not done a gastrojejunostomy in that patient, it is extremely unlikely that the endoscopy is going to be able to establish a diagnosis or help you manage that patient. The bleed is more likely to be from the pancreatic surface. And that bleed is going to be much more difficult to tackle at endoscopy. It is much better probably to do a CT scan, but sometimes you'll end up wasting a lot of time in sucking out all the blood, trying to just visualize what is happening. And a CT scan would show up bleed right there in the, this is the bowel loop which is entirely filled with blood. And this again was managed with endovascular management embolization. That was the pseudoaneurysm which has been entered into, and then it has been completely coiled. You can see all those coils in that area. So arterial complications, to summarize, are commonly seen in pancreatitis, not that uncommon. Pseudoaneurysms and bleed tend to be much more common. And once you see a pseudoaneurysm, it has to be tackled because of the risk of hemorrhage. So it is not something that you would like to observe. It adds significantly to morbidity and mortality. Bleed in a pancreatitis per se adds significantly to the mortality. Multidisciplinary approach tailored to the individual patient, but I think most of it is largely the endovascular technique being tailored to what the lesion looks like, and then timely diagnosis and management definitely helps reduce mortality. Important thing is this, that when you've got significant necrosis in acute pancreatitis or a pseudocyst in chronic pancreatitis, you may just expedite the management, definitive management for these two things as well. Thanks a lot. That's my team at Max Vaishali and Patparganj.
Thank you. Any questions?
Sir, just want to ask in phrase like chronic pancreatitis, you told bleed is not usually detected, and once the patient has bleed, they present with shock because of the surgery ruling, and RALS tube doesn't detect blood. So just to ask, there are some debate that some people ligate GDA prophylactic, some ligate SPDA prophylactic. Is it so? Is it practical?
So as far as literature is concerned, there is no routine role of named vessel ligation except for right gastropiploic, where it takes off from the GDA. Rest of it, that's part of a standard phrase procedure that I was taught while I was at All India Institute, and I have observed Dr. Ramesh as well as Lakeshore. You take multiple hemostatic sutures close to the duodenum, about 5 millimeters away from the duodenal border, all around before starting the coring. You try to core bits and pieces. I think that's more of a technical aspect of doing a phrase procedure. Prophylactic ligation is neither supported in the literature nor really recommended by people who have worked with or seen the procedure with. I would be happy to take opinions from the house as well. Anybody who does that routinely. Basically, I think the numbers for chronic pancreatitis surgery is generally not that much. And I was looking at lot of Indian literature for chronic pancreatitis, and there were like 2 or 3. The highest series that I was found was about 10, 12 cases a year. In that, to really show a difference with prophylactic GDA ligation or SPDA ligation, you take multiple hemostatic sutures before you start coring, and then you just go about it. Saket was saying something, please.
Yeah, I was just saying that in the original publication of phrase, they have said that vascularity of the duodenum should be preserved and GDA should not be ligated, either anterior or posterior. Yeah. Posterior, superior pancreato-duodenal artery should be preserved. So
we do not ligate. I haven't heard anybody doing prophylactic ligation. If you have some experience, we would be happy to hear from you, Dr. Vishal.
Some senior people, they told you they are doing GDA. There are no literature per se.
Practically speaking, when you talk about doing a GDA ligation close to the pancreatic head anteriorly, you've got the anterior inferior pancreaticoduodenal coming there, and then the posterior superior and posterior inferior pancreaticoduodenal coming here. I'm not really sure how much the GDA ligation per se is going to help. Dr. Ashok, sir.
So, GDA is not ligated routinely in Fraze procedures, neither required unless you accidentally injured during the surgery. And one of the other causes of the bleeding into the Fraze procedure is sometimes if you go too posteriorly and don't leave the posterior capsule of pancreas over the portal vein, junction with the splenic and portal vein. Sometimes the hematoma and other thing, if the cut surface of pancreas bleeds, and sometimes they erode into and there is sudden gush of bleeding, and especially this blood will come mainly into the small bowel filled with the blood, fall in hemoglobin, and if you do a per rectal examination you will find the blood clot, and abdomen will be distensions because of the fold of the small bowel. So these are the rare causes of bleeding.
Yeah.
In my practice, when I do the phrase, anyway, when you're head coring, the GDA bleeds. So I won't take the GDA ligation at the origin, but intrapancreatic I would take.
Intraparenchymal,
Yes.
so one of those, see, you are taking multiple hemostatic
Yeah.
sutures close to the C loop. So some of those sutures probably would be going through some of the GDA branches at that level.
Okay.
But per se, ligating of the name GDA, going to the hepatic artery,
Yeah.
doing some dissection there,
Yeah.
that something is
I want to give
generally
you.
not recommended.
I want to give you a clinical scenario. I mean, we had a practical problem that in one case. So patient came with the GA bleed and the CT angiogram done. It's a case of chronic pancreatitis. GDA is an aneurysm was bleeding into the pancreatic duct, and that was the cause for bleed. It was on a weekend, and IR people were not available. We had to go in. So now, yeah, I mean, getting the proximal controls is not practical it's not possible in a chronic pancreatitis. So we had to get into the, once we lift the stomach off, you could see the clot, and then once you open, it just, the torrential bleed. Of course, we had a posterior control. So we ligated transfixation of the GDA done intrapancreatic. Now my question is, so it is communicating in the pancreatic duct. If you don't do anything further, the pancreatic fistula can occur. Would you address as a fray at that point, or what's your opinion?
A lot. I would be skeptical to offering a phrase at that point in time, because quite often the patient would have lost a lot of blood by then, and but then if you required a lot of dissection, you've opened up the pancreas at that point in time, then probably push to the wall kind of scenarios. But I would generally not recommend a phrase at that
So
point in time,
here-
because you are going to open up the pancreas further. There is going to be some blood loss subsequently. Your surgery is gonna take some time. It's an emergency situation. Obviously, you have to tide over. But then, yes, if you've had to go too much into the pancreas to just really get into this,
It's a big cavity communicating the pancreatic duct. So the pancreatic fistula is bound to happen.
so actually speaking, when you look at literature, and we've had one experience where in some of these patients, instead of a phrase, some people have done a Whipple rather.
It's much more bigger procedure than a fray in
I agree.
that
But
context.
what has been done in pseudoaneurysms refractory to endovascular management with bleed or an intracystic bleed wherein multiple attempts have failed, people have gone ahead done a Whipple, because even when you do a cyst drainage, you are not really sure how much that vascular thing is totally really tackled.
Okay.
So Whipples has been reported more often than a phrase in this setting.
Okay. So in that context, you just put the drain and come out. Is that what?
I would rather do that.
Okay.
I think
Honestly speaking, I'm lucky I've never been in that situation that I've had to dig into the pancreas to kind of, I'll catch hold of this hospital's IR guy or the next hospital's IR guy, and somebody will have to come and do that.
And we
I
did
think,
the fray and patient did well.
So that's great.
scenario you are mentioning, I think you have opened up the cyst in which the bleeding has occurred. So if you have already controlled the bleeding, simply drain the pseudocyst either in the stomach or in the jejunum, rather than just going with the phrase or Whipples.
Phrase
That
is
would be
where-
a simplest procedure at that particular point of time.
Yeah. Phrase would be probably not a great procedure
So
at
the
that
scenario
point.
he's mentioning that bleeding has occurred in the pseudocyst, he has opened,
So
and
they
then
did a
what to do?
phrase.
So it is a different thing that phrase was done, but
Yeah.
simplest procedure at that particular
If the
point of
patient is
time,
hemodynamically stable and
simply you drain the cyst inside, in
yes,
the stomach or this thing.
if the patient is
Jejunum.
stable, the biggest challenge, sir, with intraluminally drained cysts in the emergency setting, what we have seen is we've done some of these transgastric, and the cysts have bled again, leading to a lot of difficulty in subsequent managing them.
No, the scenario is totally different when the IR guy is not available.
Yeah.
And my question is with you all and with Dr. Hardeep, why these vascular complication in acute pancreatitis more common in males? Is it related to the underlying etiology like alcoholic versus biliary, or it is something else?
It could probably be because, as Harjeet also showed, that they were seeing more venous thrombosis in patients who were alcoholics. It could be related to that, but I'm not sure. I'm not really sure.
Thank you. In the interest of time, we'll
Thank you.
conclude the session.